Alright, so this hopefully will be a short little section on cardiac infections and inflammation. One of the most common types of cardiac infection is known as rheumatic heart disease or rheumatic fever. And rheumatic fever is an acute systemic inflammatory condition, and it appears to result from an abnormal immune reaction that occurs a few weeks after an untreated infection. Often it's a strep infection. So the one that usually causes rheumatic fever is the group A beta hemolytic streptococcus. So it's the same thing that gives you strep throat. Unfortunately, you get that abnormal immune response, and the inflammation involves the heart and other parts of the body, such as the joint and skin, and it can even affect the brain. So it usually occurs in children 5 to 15 years of age, although rheumatic fever is not as common as it used to be, because strep infections are getting treated more quickly. People know to take their kid in to get a strep culture, and they're getting treated. So a lot of times it doesn't go to rheumatic fever, but there are other types of other strains of streptococcus that could possibly cause that infection, and so rheumatic fever can continue to appear because maybe it's not strep throat, but it's some other type of streptococcus infection. So it can really have long-term effects. A lot of times it starts out seeming like an upper respiratory infection, tonsillitis, strep throat, that sort of thing, but then it leads to other issues. So the body forms antibodies to the streptococcus organisms, and then it reacts with the tissue in your skin and your joints and your heart, causing inflammation. Usually the heart is the only site where scar tissue occurs, and that's what causes rheumatic heart disease. So there's a great chart in the book on page, 255, that talks. It's a little flow chart. I like flow charts. They just make sense to me. So sometimes seeing something in a flow chart, you say, "Oh, I see how that happens." So when you look at that figure 12.27 is what it is. There's an acute stage where the heart is inflamed, and it can involve one or more layers of the heart. So pericarditis is an inflammation of the outer layer, the pericardium, and it might include fluid accumulation or effusion, which impairs the filling of the heart. So I very briefly mentioned in a previous lecture the pericardial tamponade, which when you get effusion in that pericardial sac, the heart can't expand and fill, and so obviously that's an issue. Myocarditis is inflammation in the heart muscle, and that can interfere with heart function as well. And endocarditis is usually the most common problem with rheumatic heart disease, and it affects the valves. The valves get swollen, and you get these little these things, they're called verrucae, which is like warts sort of, but they're little growths along the edges of the valve cups, so the valve doesn't close completely. And it disrupts blood flow, and it disrupts the effectiveness of the ventricles when they're trying to pump the blood out into the body. So eventually you can get scarring on the valves, and that can lead to stenosis if the scar tissue fuses the valve together, and that leads to cardiac insufficiency, or it can end in rheumatic heart disease. So sometimes the chordae tendineae, those little muscles that hold the inside of the endocardium to the muscle, sometimes those can get inflamed, and that causes damage to the valves as well. So other sites of inflammation that can happen with rheumatic fever are the large joints of the body, particularly the legs. And it often comes out as like a polyarthritis is what they call it, where multiple joints are affected. The skin, and the hallmark with the skin inflammation is a non-pruritic rash, which is known as erythema marginatum. And it's red macules or papules that enlarge and have large white centers. So it's not itchy, but it's a red rash on the skin, and that's from inflammation in the skin. You can also get small subcutaneous nodules, which are not tender, on the extensor surfaces of the arms and legs. Interesting, right? So if the brain is affected, it's often the basal nuclei in the brain that are affected, and they cause involuntary jerky movements of the face and the arms. So, and the legs. So, that's a big deal when your heart and your brain are affected. So I guess the upshot is, if you suspect that somebody has strep, get it checked out. So not everybody has all of those signs and symptoms, and they base the diagnosis on basically the signs of inflammatory disease and high levels of an enzyme that's called anti-streptolysin O, and antibodies to that, and a history of streptococcal infection. But you have the infection, you have the low-grade fever, leukocytosis, malaise, anorexia, fatigue, tachycardia, heart murmurs, epistaxis, which is nosebleed, and abdominal pain. But the rheumatic heart disease often develops years later from those scarred valves. So they test heart function, electrocardiography. They do the titer for those antibodies to that streptolytic enzyme. It's treated with antibacterial agents and anti-inflammatory agents. So it has a lot of complications, such as heart failure resulting from valve damage. So it's something that sort of sticks with you for the rest of your life. So it can be a serious illness and eventually cause heart failure. So this is someone's mitral valve where they have that inflammation, and it's bumpy, and there's scar tissue. So you get stenosis, where the valve is narrowed, and you just don't get as good a blood movement inside the heart. And this is another example of mitral valve stenosis. So this is the chart that I was talking about from page 255. So it starts out with that antecedent infection. Sometimes you just recover from it. Other times it forms antibodies. The antibodies react with the collagen in your tissues. You get the possibly one or more of the 3 different kinds of heart inflammation. You get scar tissue, loss of valve function, and eventually the result of that is rheumatic heart disease. So it's something worth getting treated early on, so you don't ever form those antibodies and cause the problem. So infective endocarditis is another type of infection, and they used to call it bacterial endocarditis. There are 2 forms: the subacute, which is caused by a streptococcus species, and acute, which is caused by a staphylococcus species. And it's a lot of times it's some form of Staphylococcus aureus, and it tends to cause severe tissue damage. And unfortunately, now we have a lot of those multi-drug resistant organisms out there that can cause infective endocarditis. And so you really want to get it identified soon, and you want to get it taken care of before you get infected with a resistant organism. So basically, the microorganisms, however they got in there, they're in the general circulation, and they attach to the endocardium and invade the heart valves. So you get what they call vegetations, which are basically like little colonies of bacteria and platelets and blood cells that are growing on the valves, and it interferes with the closing and opening of the valves. You can also get pieces that break off that form infective or septic emboli that then cause infection in other tissues. So that is, that can cause systemic infection. So a lot of times you have low-grade fever or fatigue, anorexia splenomegaly, which is enlargement of the spleen. Congestive heart failure can result from infective endocarditis. The acute version, which is the Staphylococcus aureus version, usually has a sudden marked onset. You have a high fever that spikes up, chills, and drowsiness. The subacute version has an insidious onset. So fatigue, anorexia, cough, dyspnea, but those symptoms can be pretty vague. Usually they'll use a blood culture to identify the causative agents, and a lot of times you're on IV antimicrobial drugs for a long time. Pericarditis, that can be acute or chronic. It's usually secondary to another condition, and they classify it either by the cause or the type of exudate. So acute pericarditis can just be simple inflammation in the pericardium, like secondary to open heart surgery, MI, rheumatic fever, lupus, cancer, renal failure, trauma, viral infection. Obviously, a lot of different things can cause this. You might get effusion, where a large volume of fluid accumulates in the pericardial sac, and that leads to distended neck veins, faint heart sounds because the heart can't beat as hard, and pulsus paradoxus, which pulsus paradoxus is when the the pulse slows down during inhalation and speeds up during exhalation. It's really kind of a weird reaction. Sometimes people get that with asthma too. So a lot of things can cause it, but with that buildup of fluid in the pericardial sac, the heart can't expand to fill. So you get decreased output. That's the biggest problem with it. They treat it usually by treating the primary problem. Occasionally they will aspirate fluid from the pericardial cavity, which is called paracentesis. Anytime they take something out of a body compartment, it's synthesis. So paracentesis is where they take it out of the pericardium. Usually they will analyze the fluid, and really it could kill you if the cardiac tamponade occurs, if the effusion is severe. So it's a pretty serious, the acute version of it's pretty serious. You can also get chronic pericarditis. So it's chronic inflammation in the pericardium that basically you get adhesions between the pericardial membranes. Well, that's a problem because the heart has to be able to move in order to beat. So you can get chronic pericarditis from tuberculosis, or it can radiate from the mediastinum. It limits movement of the heart during diastole, which is the filling period, and also during systole, which is the pumping, and it results in reduced cardiac output. So you can get inflammation or infection from adjacent structures as well. And chronic pericarditis causes fatigue, weakness, abdominal discomfort sometimes, and you can get that systemic venous congestion because the heart can't fill, so you get a backlog of fluid.